Good morning.
Good morning.
I'm Cecil,
I'm Calvin.
and I guess it's morning here, but we don't know when it is when you're watching. So we wanted to get together and talk about the self-sovereign health identity service. Should we say service there?
You could call it a service.
Call it a service, and why, what it is, and why it's really needed in healthcare. So we make a big point that healthcare needs self-sovereign identity service to help people find their information and to actually make their identity across distributed healthcare. So can you tell me?
So the idea of self-sovereign means it's not hospital sovereign.
Okay, yeah,
Okay? We got the patient doing something, and it's kind of like up till now, well, in the existing healthcare world, your identity is managed and maintained and curated by each health organization in their MPI. They
Okay,
got one.
yeah.
That's and they curate that, and of course, the problem we have is that every one of those health information systems have a different MPI, and you're known by those different those different identities that are curated in those MPIs.
Yes.
And we have a big matching problem. When you go from one place to the next, knowing that that it's the same that it's the same patient. So the idea is kind of not exactly instead, but kind of like adding to it. The matching problem could be solved. A way to solve the matching problem is to have the patient carry around an information resource.
Yeah.
That held their patient IDs.
Yeah, it does seem kind of weird. I mean, I guess it's very situated in healthcare. Maybe some other people do it in a very abstract way, but like usually when I go, like I got this drink at the coffee shop and they ask my name, right?
Yeah.
I don't think they're trying to track. They're not trying to own identifying me, right? I do that task for me. I carry around that information.
Yeah.
Right? And I just say my name. Oh, I'm Cecil. And they write it down. And they have all kinds of problems because my name is Cecil and they still get the wrong mismatch.
Yeah.
Why is healthcare, so it sounds like you're saying, right? Like healthcare's trying to do that task for us.
They are, and they have your name written down.
Yeah, yeah.
So every place you go in healthcare, they got your name written down.
Yeah.
The problem is they need to match what's the same body that someone else in healthcare knows you by.
Right,
And
yeah.
names aren't good matches.
So why is it more important in healthcare?
At the coffee shop, you're in and out. Once you bought your coffee,
Yeah.
they're done with you.
Yeah, I guess I'm answering my own question.
Yeah.
It's much higher stakes.
Much higher stakes.
Because, yeah, the coffee shop does mess up my name quite a bit.
Yeah.
But all that happens is I have to wait 10 minutes while my sandwich is literally sitting in front of me.
Yeah.
And they're asking for Steve. But in healthcare, okay, right.
Yeah.
So much higher stakes, so they don't want to make any mistakes.
And they got to make sure the next time you come in, they match you to the same same body that they matched you, because they have information.
Right.
The idea that healthcare is very information intensive.
Yeah.
And so
yeah.
they got to make sure they match the information. You know, they may have done an MRI 2 weeks ago.
Yeah.
And they're now working on you. They got to make sure that MRI they did 2 weeks ago was the one off from your body. Okay, very important.
And we have the complication from like what we talked about last time of all the different entities involved.
Right.
Within one visit,
Right.
they got to pass that information from person to person and
Right. So
entity to entity.
So our idea is that in today's world where people carry around significant computing resources,
Yeah.
we could equip them. We should equip them with the tool to match their identity across healthcare. So every place they show up, instead of healthcare trying to figure out who they are,
yeah, you tell them who you are.
They tell them who you are.
Okay, I'm following you there now a lot, because previously patients or people, I have a very limited tool set for identifying myself. I have a name, right? Maybe I have a license number. That's like really pushing it. Like, I don't know that, and no one would ever use that. Name and address. It's the only way I'm equipped.
Well,
and
that doesn't name and date of birth.
Oh yeah, name, address. Yeah, name, date of birth. That's Social Security number. I don't know if people are supposed to be using that. There's problems with that.
There's they're trying everything.
So basically, and we talked about this last time too. That doesn't fit the bill when it comes to the high stakes requirements of identifying you.
Well, I mean,
your name. Other people have it.
Yeah, I mean, it fits the bill if you're willing to accept errors.
Oh, well, they're not. Yeah.
But the industry has accepted errors.
Right.
And it's kind of like, okay, let's look over the population. If we miss 2 out of 100 or 2 out of 1,000, at some point it's acceptable. We have accepted the errors associated with probabilistic matching, and many times the errors only cause, numbers to be messed up.
Yeah, I'm wondering if that's why it was somewhat acceptable. So it's not acceptable when it comes to patient safety, and you'll get armbands and beeping and stuff like that. But it's not worth it really to fix it if you're just going to lose some money here and there.
What I'm saying is, it should never be acceptable in our industry to accept a mismatch.
Yeah.
And it has become acceptable. You look at the averages. You say, okay, we have this much mismatch, and we have grown to find this problem acceptable. No one likes it. Lots of papers are written about all the problems. A lot of ink has been spilled on this problem, but the industry in general accepts it, and that's not acceptable. There's never an acceptable time when there's never a case where it's acceptable to mismatch a patient with their information, and the acceptance that the industry has should be eradicated. But that having been said, there's a lot more reasons than that, in that the cost associated with these mismatches is very high. So my point is, okay, no question that there's a lot of reason to solve the problem.
Right.
And there's a lot of reasons why we're here. We don't need to till that soil right now. But the solution of the patient carrying around the tools to avoid the problem is powerful, I think, and what we're promoting this idea that patients should match themselves to healthcare rather than healthcare seeking to match to a patient.
Yeah, okay. That's I think that seems to revolve around the self-sovereign identity, right? So this is a task.
They're carrying around something that they own, that they control.
Yeah, well, it sounds all profound, but it sounds like your normal day-to-day operation, actually. In most things, you're using self-sovereign systems. So let me go back. This seems like a task that is done now by healthcare.
Yeah.
The matching.
Yeah. You show up, they got their MPI.
Yeah.
They got thousands of records. They try to figure out which of those is you.
And then, so we're saying that this would probably be more effectively done by the patient.
Absolutely.
Right. This is no longer in the domain, or it's not really efficient. It's not really accurate to be in the domain of the responsibilities of the healthcare systems, and that we can do it. I feel like there are interesting examples of this happening. So, for instance, I I wouldn't really call it self-sovereign actually, but your insurance card, right? Insurance uses a system like that. They give you a number. Now they've equipped the patient to identify themselves.
They have
right?
in that aspect, yeah. So you show up and you give your insurance card.
So why on earth don't we just do that in healthcare? You give them a unique number, and now you've equipped the patient. Because the technology we're using right now, or demographic vectors, are not equipping the patient. The patient's not equipped to identify themselves accurately enough. Now, if we could give them a single unique number,
sure,
that would accurately enough identify them and solve all these problems. Why don't we just do that?
Sure, and of course the industry tried to do that with HIPAA. That's what HIPAA was all about.
Okay.
That's why HIPAA got passed, is because we were going to create well-recognized need and well-recognized solution. Let's get a uniform health identifier, and we all worked together, and in 1996 we passed HIPAA that authorized the Universal Health Identifier, and along with it, we had to give some specific privacy rules when we got it, and so we agreed to that. Bill Clinton signed HIPAA in 1996, and we started implementing it in 1997, and that's when the privacy advocates killed it.
Okay. Yeah.
So they convinced society that it was unacceptable to have a single number that could unlock an entire health history. That was in the bloom of the AIDS epidemic, and they rode that. And it still is authorized, but what they got, how they've killed it is every appropriation bill since has defunded any work, any money being spent by the federal government to implement it. And it would take many billions of dollars to implement it. And so it's never been implemented. And while that was happening,
why would a single number unlock? That doesn't make any sense, really. A single number is going to unlock all of their health records?
Well, if you knew what if I knew what your number was, I could go around and hack computer systems with your number.
Go around and tell people you
or
are.
Or tell people whatever I am. I mean, I agree that the industry didn't think it was unacceptable to have this number,
right?
But the privacy advocates made the case powerfully enough that what I learned in that process, so I dialogued with those privacy advocates a good bit as this was happening, and we sat on panels together, and we lost. But what I learned from them is that the fact that we have different identifiers throughout healthcare is not a flaw to them. It's a feature that they value, so that it's hard to connect this information. So they think the fact that it would be hard to match patients from one health information to another is a safeguard to privacy.
So if you ever get compromised, it's only
that one.
That one area that you're in. Yeah.
I argued all the other arguments why that wasn't really valid, but they won. And it's pretty clear to me that that's probably killed forever. Who knows what will happen tomorrow, but it doesn't seem likely that that's ever going to be changed. And actually, what happened during that period, as we were working with the rulemaking agencies and implementing it, as it was being killed, I actually proposed to the rulemaking agencies that if we aren't going to have a number, then we should have a directory,
right,
where we could correlate all the numbers that each patient is known by. And
that directory didn't smell pretty good.
We don't have that directory today. So what happened was those privacy advocates sitting at the same panel turned to me and said, "Calvin,
Yeah.
I remember this indelibly in my mind. They said, we will never allow that directory to be created because you could not create walls tall enough and put guards big enough around those walls to guarantee that no malicious attack would occur.
Right. Okay.
And that seared in my mind, because that's what, I mean, the industry needs this so badly. And so for the last 20 years, I have been seeking how to meet that objection of the privacy advocates.
Okay, the industry needs this. There's the need. And I guess you're talking about the need to match IDs.
Yeah.
The need to match IDs accurately across healthcare.
No.
So if we could find another way to do that, that also had this parameter of not, of being palatable to privacy advocates, but of not unlocking everything, right? Of not being a one-stop shop to like.
So that's really where the self-sovereignty idea emerges. Is okay, and they actually said this. They said if you created that directory, that would be so target rich.
Yeah.
That you could not protect it. You could not guarantee to us that it would be protected. So our idea now is okay, we may not be able to we can't create a directory that would have all those, but how about each person have their own directory?
Okay, so there we're getting to the self-sovereignty, because
right.
Is the key word there we, like the healthcare people.
Right.
We cannot create this directory.
That is
we
true.
Cannot create this number. Why on earth, and I'm not asking this is more rhetorical, it does seem weird, why would I worked in healthcare as well, or I work in healthcare, why would we see ourselves as the we there? Like, we have to do this, we have to solve this, because that kind of makes sense of why not patients equip them to identify, to make the matches themselves.
So it's reasonable, it's obvious why it's the we, because we are the only ones who know who we can get to do something.
Yeah.
Okay.
Yeah.
So that's the only way we really can solve problems is if we get together, we create a strategy, we go execute the strategy. So it's kind of different to think about, okay, maybe the patients could solve this problem.
It seems very low on a patient's, we even say patient, on a person. Patients are people.
Yeah.
Very low on my prioritization of my daily life is making sure my ID is matched correctly, unless I'm in the hospital.
Right.
Then it's very high. I know these problems, so it's very high. But on a healthcare, if you're a healthcare IT person, that's super high on your priority list.
Yeah, so the real challenge of it, so the self-sovereign concept is really good. I mean, you can see that could work.
In those terms, yeah.
But the real challenge of it, could you engage patients
to do some of that work?
To do that.
Yeah.
And could you rely on them to do it?
Yeah.
In a robust, to do an important function of healthcare, could we ever conceive of how we could rely on patients to be carrying out this critical function? And that's not an easy leap.
Yeah.
Okay, that's not an easy leap.
Because it's very technical and it's very important.
It's very, yeah. So I mean, so that's more of an implementation question, which is critical. Okay. But that's an implementation question, and kind of then how that doesn't mean to dismiss it, because it only works if we can solve the implementation question.
Yeah.
We know lots of good ideas that have that are on the trash heaps of history because they weren't they never achieved implementation or very much adoption. So that is a real big interest of ours. And so a couple of things on that. One is, because of that, there's no conceivable way I could conceive that you could ever figure out how to one day have patients now doing this. Let's set the date. Tomorrow we're going to now rely on patients.
Right.
It's never going to happen.
While healthcare is at risk.
Right. So that's never
You
gonna happen.
they're
But-
going to want to sue you if you mess it up.
So what it's got to be is something more like, okay, here's a tool patients can have. So we make the tool available to equip themselves to do this. Not all the patients are ever going to, probably not all the patients will ever have that tool.
Yeah, that's
And
true.
so you would have to create the tool in a way that healthcare didn't actually have to change the way they did business to use it.
Right. Yeah, that seems important.
So patients could show up without the tool and still healthcare works.
Yeah.
But when they showed up with the tool, healthcare works better.
Oh, yeah.
Okay, and so because it works better, over time, more patients would show up with the tool.
Yeah.
Okay.
So that tool, that game changer, I mean, you've talked to me at length about this. In the 80s, they gave cards with numbers for insurance to do the same task.
Right.
That's some tool they had, paper.
Right.
But now we have a new tool.
Right.
That's the key to all of this, really.
Right.
The phone.
Right.
We're talking about the smartphones.
Right.
Yeah.
And so they're capable. I mean, you can conceive lots of stuff you could build on this platform, but still, you becomes instantiated in some kind of app here. It's hard to get patients to use apps.
Oh, right. Yeah. We go that way.
It's thousands of healthcare apps, and almost, most of them don't get any use.
Right. Yeah.
Of substance. So it's not insignificant to say, okay, we could put an app on here that a tool that patients could use and would do all this stuff.
Accurately and all the time identify them and match their IDs.
Right.
But then we go a step farther. It's not just match your ID here, right? That's the whole point, right?
Yeah.
It has another special power, right, that patients have that our IT tools don't today, right? And that's that it works everywhere. It works in any network, right?
It works everywhere.
Right.
And I mean, a lot of good things happen around this if you can solve the adoption problem. But yeah, if you can conceive a world where patients are doing this, take healthcare transactions,
right,
where we're moving data
between different entities.
Right now, we have to create trust relationships
between those
entities.
Right. Yeah.
If it was self-sovereign, that the patient was involved in cross-referencing those IDs, it's totally up to the patient. The patient would only have to. You'd only do it with organizations the patient trusts.
Right. Yeah.
And it would be up to the patient. Do you trust the next organization to move your data? And so trust becomes a lot simpler.
Right.
Does the patient trust?
Yeah.
And basically, in this world, where you have self-sovereign identity, a self-sovereign health identity, all the transactions, all the stuff that's happened is outside of HIPAA.
Right.
HIPAA does not rule over what that patient decides to do with their data.
Yeah, that's why you can email your doctors and text them because
Right.
it's a patient.
Right.
That's another example,
Right.
okay, of self-sovereign, like when I use an email client, right?
Right.
That's I don't know if it's my property, but it's my email client.
Yeah.
And I'm using it.
Right.
HIPAA really regulates cross-entity on your behalf kind of stuff.
Right.
Right, okay.
Right. And you don't know what's happening. I mean, you sign this.
And they're not going to serve you unless you check the box.
Right. This HIPAA consent, and there are lots of places that your data is going to go that you don't know about.
Right.
Okay. And lots of reasons, lots of rules around that. So there's a rich opportunity to use self-sovereign health identity to solve this problem. Obviously, we've referenced it only works with, I mean, the big challenge is adoption. And we have good adoption stories, so we think we can get it actually adopted. That's not what we're talking about right now, but obviously we're doing this because we've watched a lot of adoption failures.
Yeah.
And we think we have a story that these things, if we put them in the right way, could get adopted. Importantly, they get adopted by patients first.
Yes. Yeah. Oh, yeah. I want to talk about that. Right.
And when patients adopt them, they go and they can use them anywhere they want. It works. So it needs to work. So we drive adoption from patients, and then anywhere they go, it works.
Yeah.
And so we'll do another story about that.